Okay, just to finish up the lecture from Thursday, I want to review measuring cardiac structure and function. And this is really just to highlight some of the key measurement techniques that are out there that let us evaluate the various parameters that we've discussed over the last several lectures. So all of these different modalities use different technologies. And really, we're going to talk a little bit about echocardiography in a little bit more detail than the others because they're definitely a career path. But there's also myocardial perfusion imaging, magnetic resonance imaging, that being MRI and CT. So echocardiography, this is the very, very common. It is non-invasive and really gives us a lot of information about cardiac function. It utilizes high-frequency sound waves that penetrate the body and reflect back based off of different tissue properties. If we take a look at my image over here on the right, so this is the ultrasound transducer up here. The sound waves work their way through the tissue, and as you might expect, myocardium versus the blood, different tissue properties that results in sound waves or echoes being transmitted back. And based off of that information, it can regenerate an image of what we expect to see. And this is that 2D image that we would see on our screen and that we would evaluate. And this is the left ventricle. This is a cross section. And so we're kind of looking down into it. You can imagine we could go in and assess chamber diameter. And what's really nice with the technology, we now have the ability to actually steer the sound waves and give us this really detailed information. So when it comes to echocardiography, there's the challenge of working around the thoracic cavity, that being working around the ribs and the lungs. So there's certain windows, if you will. I'm just going to highlight here so you can kind of see what I'm talking about. This panel A, this is the peristernal. C is the apical. B is the subcostal. And basically allows us to look at the heart from different directions. And if you take a look over here, we can see the different views. So this is a peristernal view. This is the aorta. This is portions of the left ventricle. Down here, this is called the apical forechamber. You don't need to know this for the exam. This is just labeling for your own interest. This is the left ventricle, left atria. Right here is the septal wall. Over here's the RV. We can actually go in and we can assess that volume of the left ventricle because it has a nice elliptical shape. There's different techniques out there for going in and assessing the volume of that chamber from this 2D image. So we can see changes in end-diastolic and systolic volume, calculate stroke volume, rest during exercise, and disease. We also want to be able to assess how quickly the flow of blood moves from chamber to chamber. And that's where the term Doppler echocardiography comes into play. So we use the Doppler principle, which is the same technique that the state trooper uses to see how fast you're traveling. Ultrasound or sound waves are emitted. They reflect off of red blood cells. And when they do that, based off the speed at which the red blood cells are moving, we get what's known as a Doppler shift. And that shift is related to the velocity of the red blood cells. And the system can convert that information into actual velocity information. So this is our 2D image of our left ventricle here. And this is we can put our sample volume right here, our measuring point. So this AO, that's the aortic valve. So flow of blood should be moving out from the left ventricle, out the outflow tract through the aorta. We put that measuring point there, we can get what's often referred to as the spectral curve, but this is the velocity. You can see the velocity of blood in the aorta. So this is the speed at which the red blood cells are moving out in a single contraction. We talked quite a bit about pump function and contractility, so it's really important to really, how do we better understand systolic function? And broadly, the term systolic function is the ability of the heart to contract forcefully enough to eject blood. So in reality, this is a broader term for contractility. And this is really challenging to measure in the intact heart. So we've got to use a different series of different techniques. The simplest is referred to as the isovolumic index of left ventricular contractility. And it's really the change in pressure or the change in time. The little d just represents change. So it's the change in pressure or the change in time or the slope. So if we come over here to my figure, here's our time. Here's our change in pressure. It's really this slope. This is the dp over dt, the slope. And it's that provides information of how quickly can the left ventricle generate that pressure, generate that force. It's difficult because it does require catheterization, so you need to be in the cath lab, and it's not the perfect scenario because it is influenced by a variety of factors. What we most often use in a variety of settings is ejection fraction to assess systolic function. And this is the ratio between stroke volume and end-diastolic volume. And normally, you're above 55%, meaning that you eject 55% of the blood in end-diastole gets ejected with each beat. Now, as you can imagine, it's going to be highly dependent on things like heart rate, preload, and afterload, but it's widely used in a variety of athletic and clinical settings. And this is the simple equation. So stroke volume divided by end-diastolic volume times 100. So if we come over here to my figure, this is my LV. We've traced it here. And we did so at end systolic volume and end diastolic. So you come over here, this is our end diastolic volume was around 110. Systolic volume was 53. That gives us a stroke volume of 57. And if we do the math, that gives us a ejection fraction of about 52%. So this is about normal, maybe a little bit low, but not far off. We need this because the American College of Cardiology has got guidelines. So normal is in that 50 to 70%. I had 55 above. That's the varies from place to place. And as you start getting lower values, you start getting into this dysfunctional range, with severe dysfunction being less than 30%. We can actually look at the importance of this. We'll look at the women here. The other side is the same just for men. This is the incidence of cardiovascular related mortality. And down here is the ejection fraction. So note that basically from here this way, incidence is very, very low. And there's a 55 to 59.9% ejection fraction, 60, 65, 70. So everything over that direction is an ejection fraction greater than 55%. And note that as we now get here, the risk goes considerably higher. Now our ejection fraction is less than 55%. You see the same thing with men. What about diastolic function? Diastolic function, again, is how well does it relax? That's the diastole, the left ventricle. It has to relax and fill. And this includes the early phase of more active ATP-dependent relaxation, where we're getting the using the circuit pumps, getting the calcium out. We get actual suction of and it's pulling blood, and then also the involvement of the elastic properties of the myocardium. All can dictate how well that LV fills. And we can assess a little bit through our pressure volume loops and compare individuals with impaired diastolic function compared to those with normal. So here's our normal. And remember our end diastolic volume relationship here. If we have someone who's got diastolic dysfunction, it's considerably shifted up. It's much stiffer, much harder to fill. Now, this requires catheterization. This is the ideal. So what do we do non-invasively? How can we assess this in different ways in response to training or disease? So this is where we go back to ultrasound. Ultrasound, using that Doppler technology to look at blood flow, we essentially look how quickly does blood move into the left ventricle. And we use that at the level of the mitral valve. Remember, that mitral valve is the valve that separates the left atria to the left ventricle. How quickly does that flow go in there? There's actually two ways, or two segments, if you will, of blood moving from the atria into the ventricle. The first we identify is the E wave. This is the early filling. If you go back up to the Wiggers diagram, that's where we get that the mitral valve opens, we get a big surge of blood going in there. And if I jump to my figure here a little bit, here's normal. This is velocity. Using that Doppler ultrasound, big E wave. If we take it, compare it down here, this is from our Wiggers diagram. Again, here's normal. Here's our left ventricle, left atria, and our aorta. During this early phase here, volume goes up quite a bit in our volume, LV, this big E wave. This is influenced by atrial pressure, left ventricular diastolic pressure, and how quickly that left ventricle relaxes. There's also then this little A wave. And this is the component of atrial contraction, that little atrial kick that corresponds to our P wave. So we see this little A wave. And that gets this little kick here. That's associated with the left atrial contraction. Both of these provide information, and their ratio is really important to provide us information about diastolic dysfunction. So if we start looking at here, impaired relaxation, restrictive filling, we start to see that ratio change in a very dramatic way. You don't need to know these, just know that what the E wave is and the A wave and that EA ratio provides information of diastolic function. And that's all we have for this. Like I said, it was just the last little bit of the lecture we couldn't get to. Hopefully this was informative and helpful.